Hi everyone, my name is Steve Evener and I am an ORISE Fellow in the Surveillance and Data Management branch of the Division of STD Prevention at CDC. It's a pleasure to be presenting to you today about a survey CDC conducted to better understand how gender identity is collected and reported for cases of nationally notifiable STDs. Numerous studies have documented inequities in the burden of sexually transmitted diseases by sexual orientation and gender identity, collectively referred to as SOGI. For example, higher rates of HIV and other STDs have been found by Shover and colleagues among transgender people seeking sexual health services from federally qualified health centers in Los Angeles, as well as the Center for Transgender Equality and National Gay and Lesbian Task Force collaboration that surveyed transgender and gender nonconforming people from all 50 states, DC, Puerto Rico, Guam, and the Virgin Islands. There are some states and local STD programs that routinely collect SOGI data and information on the sex of sex partners for persons diagnosed with STDs as part of disease investigations. However, these data have not historically been available for analyses nationally. In addition, sexual minority communities have advocated for greater visibility and representation among federal systems in disease surveillance so that national policy can begin to address the inequities based on sexual orientation and gender identity. Taken together, there is a need to collect population-level data within disease surveillance systems to better characterize the burden of disease in these populations. In 2017, CDC proposed adding data elements to the National Notifiable Disease Surveillance System that captures SOGI data and received provisional approval from the Office of Management and Budget to collect these data. The two elements were separate from each other and labeled as optional. Sexual orientation can be coded as gay or lesbian, straight not gay or lesbian, bisexual, something else, or unknown. For gender identity, codes include transgender male to female, transgender female to male, transgender unspecified, cisgender / not transgender, or unknown. If a code was not selected for either, unknown was the default code. CDC provided guidance to state and local STD surveillance programs for implementing SOGI data elements through the NETS CDC implementation plan in January of 2018. Jurisdictions were requested to begin reporting these data at that time. As part of the Paperwork Reduction Act and to justify approval of data collection, OMB requested an evaluation of the level of burden involved in collecting and transmitting these data. 19 jurisdictions successfully implemented these data elements and immediately began reporting SOGI data for diagnosed and reported STDs. These initial 19 jurisdictions were invited to participate in a brief telephone survey to evaluate their level of burden as requested by OMB. The survey included questions about when SOGI data collection began, when these data elements were added to or modified within their surveillance systems, and how these data are currently collected. Here are the 4 survey questions. Question 1 asked if there is a data element in their STD surveillance data management system that records patient sexual orientation, and if so, when was it added? The same question was asked for gender identity. We also wanted to know what sex was selected for transgender persons before the new gender identity data element was implemented. If their data management systems do not record patient gender identity, we asked if they capture transgender as a valid response code for sex of patient. Question 3 assessed modifications needed to surveillance systems in order to report SOGI data. Modifications were characterized as minor, medium, or major, and the estimated cost was calculated by multiplying the total number of hours spent modifying systems by the cost per hour in dollars. And finally, question 4 asked jurisdictions to check all the sources available for collecting SOGI data. I won't read all the options, but I will point out that surveillance-specific patient interviews are similar to disease investigations. These interviews are conducted in select cities such as the STD Surveillance Network, SUN for short, or the Strengthening U.S. Response to Resistant Gonorrhea, SURGE, that collect additional behavioral information for cases of STDs. Historically, the sex of sex partners reported has been a reasonable proxy for sexual orientation when the sex of the sex partner is the same as the patient's current sex. But gender identity has been problematic in national STD reporting and isn't represented in CDC's STD surveillance report. Unlike sexual orientation, there is no similar proxy for gender identity. Providers report current sex for patients, but since current sex may not always align with the sex assigned at birth, this may lead to misclassification and underrepresentation of transgender people in surveillance data. So, because gender identity data are not available through other proxy measures, and the visibility of transgender populations is an important emerging area of concern for STDs, our talk today focuses only on gender identity. This map shows all 19 initially reporting jurisdictions that began reporting SOGI data for at least some cases of STDs in 2018 and were contacted to participate in the survey. Out of the 19 jurisdictions, 12 agreed to participate, and 11, which are colored in green, successfully completed phone surveys. Phone surveys lasted approximately 20 minutes, and all surveys were administered and completed in November and December of 2019. All jurisdictions reported the ability to record gender identity data in their data management systems. Several data management systems were represented, with PRISM being the most frequently reported. Only 3 jurisdictions reported needing modifications to their data management systems in order to report SOGI data. 2 reported minor modifications valued between $1,600 and $7,200, and the 3rd reported more extensive modifications valued at approximately $30,000. Those who reported not needing modifications also reported that the gender identity element was already part of the systems they were currently using. For cases of gonorrhea and chlamydia, respondents reported that the least productive source for gender identity data was laboratory reports, followed by electronic case reporting. The most complete source for gender identity data, outlined in red, was disease investigation/partner services, followed by case reports from providers. For case reports submitted by providers, jurisdictions added that providers seldom collect gender identity data or document these data in their medical records. In addition, follow-up calls with providers for cases of chlamydia and gonorrhea are generally conducted only if there is a co-infection with syphilis or HIV. For cases of syphilis, the results were similar, with laboratory reports being the least productive source and disease investigation/partner services being the most successful method. In conclusion, we found that identity data are primarily collected through disease investigation services for cases of nationally notifiable STDs. With over 1.7 million cases of chlamydia, 583,000 cases of gonorrhea, and 115,000 cases of syphilis reported in 2018, gender identity remains unknown for most cases of chlamydia and gonorrhea, as the volume of cases may prohibit all cases from being investigated. Because case reports by providers and follow-up calls with providers were reported as important sources for gender identity data, additional provider education may be needed to make sure SOGI data are collected at the point of care. Recent studies examining providers' attitudes toward collecting SOGI data reveal that although providers believed these data would be helpful in treating their patients, they also believed that patients would not be willing to provide these data. However, the same survey of patients revealed that they would be more than willing to provide those data than providers actually think. We also may learn more about additional barriers by studying jurisdictions that are not currently transmitting gender identity data to CDC. Finally, there is a need to continue collecting SOGI data to better represent sexual and gender minorities in national STD surveillance data and to begin measuring and addressing health inequities among them. Based on our survey responses, we are confident in recommending ongoing collection and reporting of gender identity data for cases of nationally notifiable STDs. We found that these data elements were implemented with fairly low burden among reporting jurisdictions. Though there were some local changes in data systems that needed to be prioritized, the burden of those changes may be minimized as system developers provide upgrades that reflect best practices in collecting patient demographics. The Division of STD Prevention remains committed to working with state and local partners as they improve their capacity to monitor the burden of STDs among all vulnerable and at-risk populations. I would like to thank my co-authors for their support and guidance during data collection and in the preparation of our abstract and presentation. We would also be remiss if we did not thank the STD surveillance staff in these jurisdictions for their time and thoughtful responses. Thank you.
Hello everyone, this is Manjari Joshi from New York State Department of Health. Today I will be talking on estimating sexually transmitted infection rates among transgender and gender non-conforming non-binary person in New York State, excluding New York City, for 2015 to 2017, a population level analysis. In this presentation, I will go over background, methods, results, and the next step for the study. To start with background, some of the terminologies to keep in mind for the purpose of this presentation. Sexually transmitted infections or STIs include early syphilis, chlamydia, and gonorrhea. Reporting period for STIs is between 2015 and 2017. Statewide Planning and Research Cooperative System, or SPARCS, is an all-payer database for all hospital inpatient and outpatient services. Transgender or TGNCNB persons are people who identify as transgender or gender non-conforming non-binary. For purpose of this analysis, individuals with transgender experience are persons identified or reported as transgender by ICD-9 or ICD-10 codes in a given time frame based on APD data. Background. STI rates are highest they have been in 20 years in the US. Due to system limitations and underlying data quality, STI morbidity among transgender persons has only been estimated for limited setting and is widely unknown. Inclusion of transgender or gender non-conforming non-binary categories in the data will accurately reflect the burden and rate of STIs in the population. Here in New York State, excluding New York City, there has been no presentation of STI data by current gender identity. We represent STI rates by region, again excluding New York City, by sex at birth, and by race and age. To most effectively promote sexual health equity and sex positivity, we need to understand STI rates by current gender identity. Population analysis. Why is it important? It helps reveals ways to enhance patient care and improve public health. It helps discover answers to questions that cannot be found with individual studies or clinical trials. We conducted population level analysis to develop a broader understanding of STI rates by current gender identity, and to also see if we had to make any changes to existing policies. The purpose of this study is to use existing data sets to calculate estimated rates of STI among transgender persons in New York State, excluding New York City. Now the methods. We use different data sources and statistical methods. The different data sources include PERFIS, Behavioral Risk Factor Surveillance System, CDIS, Communicable Disease Electronic Surveillance System, MIS, the Management Information System where partner services investigation data is stored, and APD, the New York All-Payer Database. CDIS and MIS is used on daily basis, so we had access to it to conduct STI surveillance and partner services work. We had to make special requests for PERFIS and APD data. Different statistical methods include a mix of probabilistic and deterministic record linkage. Multiple system estimates were conducted and STI rates were calculated. Using the different data sources and the statistical methods, estimated STI rate among transgender was calculated, and it was approximately 124 per 1,000 population. Now we will see how did we get to it. First, identification of transgender persons diagnosed with an STI was done using New York State STI surveillance system. Individuals who reported STI cases to the New York State Surveillance Registry between 2015 and 2017 were included. 127,056 individuals were identified. For these individuals, gender identity ascertainment was done using CDIS and MIS. Methodology for gender identity ascertainment was presented at a poster in NCST conference in 2019. The link for the same is at the bottom. By doing gender identity ascertainment, 0.29% or 371 individuals were identified as transgender persons. STI rate of 2.57 per 1,000 population was calculated. Earlier, I had showed the finding of this study show the STI rates among transgender population was approximately 124 per 1,000 population. For all the individuals identified in the surveillance registry, a unique identifier was generated with a combination of last name, first name, date of birth, and sex. Next, identification of transgender persons diagnosed with an STI using New York State all-payer database was done. Individuals with an STI identified by using ICD-9 and ICD-10 code in APD data between 2015 and 2017 were included. 21,880 individuals were identified. Among these individuals who had a transgender-related ICD-9 or ICD-10 codes between the year 2007 and 2017 were identified as individuals with transgender experience. 0.68% or 149 individuals were identified as transgender persons. STI rate of 1.06 per 1,000 population was calculated. Again, as we had seen before, the finding of this study shows that the estimated STI rates among transgender was approximately 124 per 1,000 population. Similarly to the individuals identified in the STI registry system, a unique identifier was generated for all the individuals identified in the APD data with a combination of last name, first name, date of birth, and sex. Using unique identifiers from both datasets, probabilistic and deterministic record linkage was done. 127,056 unique IDs from STI registry and 21,818 unique IDs from APD data source were matched by inner join. Individuals were given different scores depending on which criteria of the unique ID they matched on. Different criteria are listed in the over. By doing an inner join, 3 individuals with STI were identified as transgender in both the datasets. Multiple system estimate methods. Why did we do it? It is advocated in estimating completeness of a registry. We wanted to study the estimated STI rates among transgender population using all the data sources we had access to. Multiple system estimate methodology has 2 assumptions. The 2 sources are independent and all individuals have the same probability of being identified. We met with both the assumptions. This is a table that shows the multiple system estimate methodology. We have to keep in mind that this is not a 2x2 table that we would typically use in an epidemiological study. N1 represents the number of records identified in both data sources. N2 represents the number of records identified in source A only. N3 represents number of records identified in source B only. N4 is calculated by using a formula N2 times N3 divided by N1. Thus, N4 represents the estimated number of individuals missed by both the system. Now the results. Results from all the previous statistical methods are plugged into this table, and N4 was calculated by using the formula. N4 equals 17,909. Thus, 17,909 represents the estimated number of transgender individuals with an STI who were missed by both the system. Then we calculated the STI rates by using the estimated number of transgender individuals as the numerator and Burfe's data as the denominator, and we got the estimated STI rate as 124 per 1,000 population. Next steps. A population level STI rate among transgender persons accounting for possible data missingness was estimated for the first time. The results suggest that the use of individual data sources may lead to underestimating true disease burden among transgender people. Until large data systems can fully incorporate gender identity data and all healthcare providers create safe environment for people to disclose their gender identity data, statistical methods may be needed to estimate population-level morbidity among transgender persons when making resource allocation and intervention design decisions. Thank you for listening. I would also like to acknowledge Fantra Dreme to help make this presentation. Thank you.
Hello, I'm Katie Town, an epidemiologist within the Division of STD Prevention at CDC. My pronouns are she, her, and hers. Thank you for joining me today to hear about our analysis of STD testing among transgender women living with HIV in the United States. I have nothing to disclose. To begin with, I'd like to reflect on what we currently know about the sexual health of transgender women in the US. A recent systematic review by Prevalence et al. Estimated the prevalence of HIV among transgender women to be 14%, which is higher than other vulnerable populations. HIV infection was particularly prevalent among Black or African American transgender women. The behaviours that increase the risk of HIV infection for transgender women may also increase their risk of acquiring a sexually transmitted disease. Prevalence et al. Found that over a third of transgender women reported sex work, condomless sex, or multiple sexual partners. However, among the included studies, there was a wide range of estimates for these behaviours, and half of studies included people at higher than normal risk of HIV. In the US, it is recommended that people living with HIV are tested annually for STDs. This includes transgender women. However, data on STD testing and prevalence among transgender women in the US are limited, as demonstrated by the systematic review published by Van Gerwen et al. This year. Only 5 studies from the US were found to include data on bacterial STDs, and 4 of these included data from 1 city only. Our study aims to add to the limited information on sexual behaviours and STD testing among transgender women by exploring a data source collated by CDC that includes transgender women with diagnosed HIV in the United States. This is the Medical Monitoring Project. Our objectives were to describe the characteristics of transgender women and estimate the STD testing prevalence. The Medical Monitoring Project is a nationally representative survey of clinical and behavioural characteristics of adults diagnosed with HIV in the United States. The dataset is composed of data from participant interviews and information abstracted from medical records at the usual place of HIV care. We used data collected during June 2015 to May 2018. 148 transgender women were identified. People were interviewed about their demographics, HIV care, sexual behaviours in the past 12 months, and STD testing. Viral load tests from the past 12 months were also abstracted from available medical records of the facility where participants received the most HIV care. Moving on to the results. Most transgender women reported their race or ethnicity as Black or Hispanic. In the past 12 months, most transgender women received outpatient HIV care and were virally suppressed at the time of the most recent viral load tests. Over half of transgender women diagnosed with HIV were not employed, and nearly 3/4 were living at or below the poverty level. Over half of transgender women were sexually active, defined as any anal or vaginal intercourse in the previous 12 months. The characteristics of these transgender women were similar to the results for all transgender women diagnosed with HIV. In terms of their sexual behaviour in the past 12 months, 58% reported at least one instance of condomless sex. Most reported only having male sexual partners, and the median number of male partners was 2. We found around half of transgender women with diagnosed HIV had been tested for gonorrhea or chlamydia in the previous 12 months. 2/3 of people had been tested for syphilis. So in conclusion, we've identified a gap in sexual health services for transgender women diagnosed with HIV. Less than half of people received the nationally recommended annual STD test, and a proportion of these women have had condomless sex, putting them at risk of acquiring an STD. Although most women are receiving outpatient care, not all are being tested for STDs as part of this care. Therefore, it's clear that STD testing among transgender women living with HIV needs to improve, and that HIV care visits may present opportunities for increasing STD testing in this population. The next steps of this analysis would be to extend the number of years included This should help us to investigate some of the questions we weren't able to explore with the current data, such as STD diagnoses and information about transgender men. Thank you all for listening, and I would like to thank my co-authors, plus the sites and participants of the Medical Monitoring Project.
Good afternoon, everyone. My name is Dr. Olivia Van Gerwen. I am an infectious diseases physician at the University of Alabama at Birmingham. I recently just completed my ID fellowship at UAB and currently am a postdoctoral fellow for the T32 on health outcomes and effectiveness research at our institution. And in the fall, I'll be beginning a faculty position at UAB. So today my talk will be on genital and extragenital chlamydia and gonorrhea among women in HIV care in the United States between 2005 and 2016. I have no financial disclosures, but my work is supported by a T32 training grant from the Agency for Healthcare Research and Quality. To begin, I'll point out some demographic information regarding transgender people in both the United States and worldwide. So it's estimated by the Williams Institute from their report in 2016 that approximately 1.4 million adults in the United States identify as transgender. And this represents about 0.6% of our total population. You can see on the map that there are dark blue states, which represent places where there's a higher percentage of adults identifying as transgender compared to the paler states. And then as far as worldwide, it's estimated that about 38.5 million people identify as transgender. HIV is a common issue in this community, especially among transgender women. From a global perspective, the WHO reports that there is a worldwide prevalence of HIV among transgender women of about 19%. And this is certainly a high number, but it is important to note that some observational studies in certain parts of the world estimate prevalence locally of up to 49.6% for this population. Also of note, transgender women are 49 times more likely to be living with HIV than any other group of adults of reproductive age. And this study focuses on transgender women, but I would like to bring up that transgender men are also a population that is affected by HIV, with very limited groups of data estimating high prevalence of HIV, about 8.3% in some studies on this population. In the United States, you can see some of our prevalence data here. Also very common among transgender women. The estimates of prevalence among all transgender women is about 27.7%. And among Black transgender women, it's even higher with 56.3% prevalence estimated. There are some data to suggest that lots of HIV diagnoses each year are affecting these communities. From 2009 to 2014, 2,351 transgender people received an HIV diagnosis in the US, and among them, transgender women were by far the most commonly affected, with 84% of those being transgender women. Now, HIV is known to be the most well-studied STI among LGBT populations, but particularly among transgender individuals, with other STIs like chlamydia and gonorrhea having less data in the literature. But we do know from clinical experience and the limited data that exists that these are common issues faced by transgender women. The global prevalence from some studies is estimated to be as high as 13% for both gonorrhea and chlamydia, regardless of HIV status of the transgender women in those studies. And there are some international observational data to suggest that the prevalence of extragenital chlamydia and gonorrhea is far higher than that of urogenital infection. So with that background, our objective was to identify testing rates, prevalence, and predictors of genital and extragenital, and I'll say extragenital. In our case, we refer to rectal and pharyngeal sites. Chlamydia and or gonorrhea among transgender women accessing HIV care in the United States. The hypothesis that we were operating under was that extragenital chlamydia and gonorrhea infections will be more common than urogenital infections. And the primary outcome of our study was a positive chlamydia or gonorrhea test at any anatomical site during the study period of 2005 to 2016. So this is a retrospective cohort study in which we examined adult transgender women living with HIV and enrolled in the United States Centers for AIDS Research Network of Integrated Clinical Systems, also known as the US CNICS cohort. And this is a prospective clinical cohort of about 32,000 adults engaged in HIV care, and it spans across 8 clinical sites in the United States. The data for this cohort are collected from electronic medical records as well as patient-reported outcomes at their routine HIV clinical care visits, and the data are assessed regularly in order to be updated. So in order to be included in our study, we looked at transgender women living with HIV in this cohort, and we analyzed the data from years 2005 to 2016. In order to, and we also looked, as I mentioned in our objective, at the chlamydia and or gonorrhea testing performed at genital and extragenital sites. This diagram shows the numbers of individuals that were engaged in HIV care and then the testing information as far as how many were tested and at which sites. So overall, there were 312 transgender women who were identified as being in care, that they had various HIV visits throughout the study period. And of these 312 women, we identified that 252, or 81%, were tested for chlamydia or gonorrhea at least once during the study period. And regarding the sites that they were tested at, 218, or 87%, were tested at the urogenital site, 115, or 62%, were tested at the rectal site, and 139, or 55%, were tested at the pharyngeal site. There were 125, or 47%, that were tested at an unspecified non-genital site, and it's unclear whether or not these were rectal or pharyngeal, as they were not appropriately labeled. Next, we looked at annual testing rates of chlamydia and gonorrhea by anatomical site in these women. Of note, we did not include 2005 in this diagram because there were very low numbers of tests performed that year. There were only 17 done. So this shows the annual testing rate between 2006 and 2016. So overall, the testing rates ranged from 38 to 64%. This is shown by the blue line. So 38 to 64% of transgender women tested each year. And then the orange line shows genital testing and the green line shows extragenital testing. So as you can see, they're fairly similar, but as far as the ranges go, the urogenital testing rates in this time frame ranged between 23% and 53%. And the extragenital testing ranged between 24 and 47%. Over time, there was a trend toward more testing over time. This next figure is showing our annual positivity rate for gonorrhea and chlamydia among transgender women in this cohort. And just before we get into that, among the 252 women that I mentioned, that 81% who were screened for chlamydia or gonorrhea at least once, 55 of them, 22% of that group, had a positive test of some sort. But the annual positivity rates are shown here. And overall, the positivity rate was 11 per 100 person years, but the range, as you can see here, was between 5 per 100 person years in 2007 to 18 per 100 person years in 2016, which shows that there was an increasing in annual positivity rates over time, as you can see by this trend dotted line here. And I think this figure is very important, and it speaks to our hypothesis. So we took the number of positive tests for chlamydia and gonorrhea by anatomical site, and we looked to see what the makeup was there. So as you can see, the green box of the bar represents extragenital infections, and the yellow box represents genital infections. So of the positive chlamydia tests that were performed, 67 of those were at the extragenital site, which was about 80% for chlamydia. And then for gonorrhea, same story, 51 of the tests performed, which was about 82%, represented an extragenital infection. And finally, here are the results of a multivariable and univariate analysis that was conducted to look for predictors of chlamydia and gonorrhea infection among transgender women with HIV. When we ran the multivariable models, the three predictors that we found to be clinically significant were age, engagement in care, and CD4 count. For age, the younger ages were more at higher odds of having a positive chlamydia or gonorrhea test. And then for engagement in care, the more engaged patients were in care, the higher odds it seemed that they were going to have a positive chlamydia or gonorrhea infection. Similarly, the CD4 count, as it rose, the higher the odds were that someone would have chlamydia or gonorrhea positive when they were tested. We think that the latter two predictors, the engagement in care and the CD4 count being high, reflect a testing bias, that people who are in care are more likely to be tested more frequently, and therefore it's more likely that they will catch a positive test in those individuals. So in conclusion, I think the important things that we found from these data were that the numbers of tests performed for chlamydia and gonorrhea are low for both genital and extragenital sites for transgender women in our HIV care cohort. The numbers are just not high enough for this group that is at high risk of contracting bacterial STIs, both because of sexual behaviors and gender identity related issues that transgender women face, such as sex work, multiple partners, and unprotected sex, but also the fact that they have HIV, which can lead to a higher level of transmissibility of other STIs, particularly if women are uncontrolled. The other really important conclusion to draw from this data is that the majority of infections among transgender women are occurring at extragenital sites. We did not parse through the pharyngeal versus rectal sites as far as how often those different extragenital sites were affected, but I think that would be a very interesting thing to look at in the future. And then finally, we saw, as I mentioned, that younger age, engagement in care, and high CD4 count are significant predictors of infection. And from this work, I think it's important to note that the STD CDC treatment guidelines currently recommend frequent testing among transgender individuals, but I think it would be really important, based on these data, that we could consider making a more concrete recommendation of screening maybe every 6 months for this population at extragenital sites, particularly at the rectal site. And with that, I'd just like to acknowledge all of my collaborators who are all listed here from the various scenic sites, in particular, Dr. Jody Dionodum and Dr. Jeannie Marazzo and Dr. Ashutosh Tamain, who are my colleagues at UAB. as well as everyone else listed here, my mentor, Christina Musney, and the other individuals who have helped me through my career as a fellow and now as a new faculty member. So I'd be happy to answer any questions when this is broadcasted at the conference, but also my email is here if anyone would like to contact me with further questions or comments. Thank you.
I want to thank the conference organizers for inviting me to present on STI testing and screening amongst transgender and non-binary patients attending the Sexual Health Clinic in Seattle, Washington. I want to begin by acknowledging my privileges as a cisgender researcher and that this is a limitation of the present analysis. There are no specific recommendations for STI screening amongst transgender and non-binary people. Current guidelines suggest that clinicians screen patients based on their current anatomy and sexual behaviors, but do not provide specific recommendations on types or frequency of screening. In addition, there's limited information on extragenital infections and screening rates amongst trans and non-binary people. In a study of 6 jurisdictions within the STD surveillance network, Patasi et al. Found that a high prevalence of extragenital infections, ranging from 12 to 17%. They also found that transgender patients received less frequent extragenital testing compared to urogenital testing, and that transgender men were less likely to be tested for extragenital infections than transgender women. At the Sexual Health Clinic in Seattle, Washington, approximately 3% of patients are transgender or non-binary. In December 2018, the clinic implemented trans-inclusive questions about anatomy, sexual behavior, sex partners, and STI symptoms into the clinic's CASI intake questionnaire. This analysis had 2 aims. First, we assessed if the addition of trans-inclusive questions about exposure history and symptoms increased the proportion of trans and non-binary patients who received testing. And with the availability of new data, we also assessed the proportion of asymptomatic patients who received appropriate anatomic site-specific STI screening. Please see my earlier talk on the implementation of trans-inclusive questions about anatomy and surgical procedures for additional methodological details. In brief, all patients are asked about their gender, sex assigned at birth, and pronouns. Transgender and non-binary patients are then asked a set of questions about their current anatomy, previous surgical procedures, and current hormone use. Lastly, all patients are asked questions about sexual behavior, exposures, symptoms, etc. For trans patients, we use conditional branching logic based on their sex assigned at birth and reported surgeries to ask relevant questions. For cisgender patients, logic is only based on their sex assigned at birth. Across both time periods, data was collected on gender, sex assigned at birth, gonorrhea and chlamydia tests by anatomic site conducted at each visit, and syphilis and HIV tests conducted at each visit. For our first aim, we compared the proportion of trans and non-binary patient visits that received testing before and after implementation of the trans-inclusive questions. Clinic policy is to test patients with penises for urogenital infections only if they are symptomatic. And because we lack data on symptomatic cases amongst trans patients before December 2018, we are unable to make this comparison across time periods. For the second aim, we utilized the additional data that became available after December 2018. This included information on gender of sex partners, sexual exposures, and self-reported STI symptoms. We used these data to calculate the proportion of asymptomatic patients who received appropriate anatomic site-specific STI screening based on their reported sites of exposures. From May 2016 to December 2018, the clinic saw 591 visits from trans and non-binary patients. And from December 2018 to December 2019, there were 280 visits. Notably, 63% of these patients were non-binary and 54% were white. There was no difference in gender, race, or age of the trans patients who attended the clinic between these 2 periods. Our first aim asked if the addition of trans-inclusive CASI questions about exposure history and symptoms increased the proportion of trans non-binary patients who received STI testing. We observed that pharyngeal gonorrhea and chlamydia testing increased by 13 percentage points, and that rectal gonorrhea and chlamydia testing increased by 10 percentage points after the implementation of trans-inclusive questions. There were no changes in vaginal gonorrhea and chlamydia testing, syphilis, or HIV testing between the two time periods. We also observed that increases in testing varied by gender. Pharyngeal testing increased amongst trans women, trans men, and non-binary people assigned female at birth, while rectal testing increased only amongst transgender women and non-binary people assigned female at birth. This figure shows the testing positivity across both time periods. Trans women are light purple, trans men are dark purple, non-binary people assigned male at birth are teal, and non-binary people assigned female at birth are blue. Testing positivity did not vary between the two time periods. Across all 871 visits, we observed that non-binary people assigned male at birth have the highest prevalence of STIs, particularly for gonorrhea. Rectal chlamydia was also common amongst trans women, trans men, and non-binary people assigned male at birth. And syphilis was highest amongst transgender women. Non-binary people assigned female at birth had the lowest prevalence of STIs, with only 5% rectal and 4% of urogenital chlamydia positivity. Notably, the prevalence of HIV was very low, with only 1% of trans women testing positive for HIV. For our second aim, we asked what proportion of asymptomatic patients received appropriate anatomic site-specific STI screening. Across the top, we observed that exposures varied by gender and anatomic site. Trans women and non-binary people assigned male at birth more frequently reported rectal exposures. Across the bottom, we also see variation in reported symptoms, where people assigned female at birth were significantly more likely to report urogenital symptoms. Among asymptomatic patients, transgender women and non-binary people assigned male at birth were significantly more likely to receive appropriate extragenital screening. This disparity is greatest for non-binary people assigned female at birth. Only 20% of those who reported receptive anal intercourse were screened for rectal STIs. This may in part be explained by the gender of their sex partners. However, we observed that most trans and non-binary patients reported having sex with cisgender men in the last year, and this is slightly higher amongst trans women and non-binary people assigned male at birth. Notably, trans and non-binary patients also frequently reported sex with other trans and non-binary people. When we compared people who reported any sex with cisgender men in the last year versus none, we see that trans patients who had sex with cis men were significantly more likely to be screened for gonorrhea and chlamydia across all anatomic sites, with the largest disparity observed in pharyngeal screening. In conclusion, we observed that implementing trans-inclusive questions in the Sexual Health Clinic's intake questionnaire was associated with an increase in the proportion of patients who received extragenital testing. In addition, these new data allowed for us to evaluate whether or not trans patients received appropriate screening, and found that extragenital screening remains suboptimal for trans men and non-binary people assigned female at birth, and that as well as among patients who did not have sex with cisgender men. STI prevalence also varied by gender and sex assigned at birth. Non-binary people assigned male at birth had the highest prevalence of gonorrhea at all anatomic sites. Trans women had the highest prevalence of syphilis, and transgender men and women had similar prevalences of chlamydia at all anatomic sites. Our analysis also had several limitations. First, there were small sample sizes in the post-implementation period. And second, the prevalence of STIs may be biased by the low rates of extragenital testing amongst trans men and non-binary people assigned female at birth. Lastly, I would like to thank the patients who attended the sexual health clinic, my mentor, Lindley Barbie, and my co-authors. Thank you.